2 months before the attack, the fix already existed. That spring, Microsoft shipped a patch that closed the very flaw the attackers would use. Then, on a Friday in May, the attack came anyway, locking hundreds of thousands of computers across 100 countries and freezing hospitals across England. Investigators would call it relatively unsophisticated, something ordinary security should have stopped. So why did a fix that already existed never reach the people who needed it? The truth leaves a paper trail. Let's follow it. Findings of fact. On the 12th of May, 2017, a ransomware worm called WannaCry swept through more than 200,000 computers in at least 100 countries. And in England, it disrupted the National Health Service. This episode is built on the official record, the National Audit Office investigation, the government's own lessons learned review, and United States court filings. We will trace how a known flaw, an available fix, and years of warnings ended in a national emergency, and what investigators concluded had to change. A Friday afternoon. The first signs came late in the morning. Individual hospital trusts began calling the national bodies that oversee them, reporting that computers were locking up. By early afternoon, the reports were arriving from all over the country at once. That simultaneity was the tell. A single hospital struck by malware is, sadly, not news. Hospitals across England struck within the same hour is something else entirely. It meant this was not spreading the usual way, through someone opening a bad email attachment. It was spreading on its own. At 4 o'clock in the afternoon, National Health Service England declared the attack a national major incident. The response ran through its major incident protocol, the same team that would deal with any other national emergency. But this incident behaved differently from anything the plans had rehearsed. It was invisible. It was everywhere and nowhere, and no one yet knew how large it was. According to the National Audit Office, the independent body that scrutinizes public spending for Parliament, the attack reached at least 80 of the 236 hospital trusts in England. Of those, 34 were infected and locked out of their own devices. Another 46 were not infected, but were disrupted anyway because they shut down their systems as a precaution. Beyond the hospitals, a further 603 other health organizations were infected, including 595 general practitioner surgeries. Doctors reached for pen and paper. Test results stopped flowing, and a quiet clock began ticking on every appointment that could not go ahead. It is worth pausing on what being locked out actually meant inside a hospital. When staff were shut out of their devices, they could not reach or update patient information. They could not send test results to a patient's own doctor. They could not always transfer or discharge patients smoothly from one part of the hospital to another. And it was not only office computers. Some medical equipment was locked too, or had to be pulled off the network to stop it being locked. The National Audit Office recorded that radiology and pathology departments were disrupted, the departments that run scanners and that test blood and tissue. In one example the report gives, a trust could not send the results of a magnetic resonance imaging scan to the clinicians who needed them elsewhere in the building. The machines still worked. The information simply could not move. The disruption was also uneven across the country. Of the 34 trusts infected and locked out, 29 were in the north of England and in the Midlands and East. National Health Service England's own view was that this did not reflect worse security in those regions. It reflected timing. Those organizations had been hit early on the 12th of May, in the window before anything stopped the malware spreading. That window, and how it closed, is a story we will come to, what was actually spreading. To understand why this attack moved so fast, we need two ideas, and we will take them one at a time. The first idea is ransomware. Ransomware is a program that encrypts the files on a computer, scrambles them using a secret key, and then demands payment to unscramble them. WannaCry demanded roughly $300 paid in the digital currency Bitcoin. That much was ordinary. Criminals had been doing this for years. The second idea is what made WannaCry extraordinary. Most ransomware needs a person to let it in, a click, a download, an opened attachment. WannaCry did not. It was also a worm. A worm is code that copies itself from computer to computer across a network without anyone doing anything at all. To spread, it used a weakness in a piece of Windows plumbing called Server Message Block, or SMB. This is the ordinary machinery Windows uses to share files and printers between computers. The specific flaw had a catalog number. It was tracked as CVE 2017-0144. The tool that attacked it was known as Eternal Blue. Here is how American federal investigators described its behavior. Once WannaCry infected a machine, it installed itself quietly as a background service. Then it went hunting. It scanned the local network, address by address, looking for the file-sharing port that the flaw lived behind. It also reached out across the open internet, generating addresses almost at random and knocking on doors far away. Wherever it found another vulnerable, unpatched computer, it climbed in, planted a copy of itself, and started the search again. No email, no click, just one unlocked door leading to the next. There is a further detail worth stating, because it shaped how the day was reported. WannaCry did not arrive fully formed. American prosecutors would later describe 3 versions of it. The earlier 2, from February and from March and April of 2017, could only spread inside a network that the attackers had already broken into, using stolen passwords. They stayed small and went almost unnoticed. It was the 3rd version, released on the 12th of May, that added the self-spreading worm. That single change, bolting the internet crawling engine onto ordinary ransomware, is why this version, and only this version, spread to so many computers in so many countries, and the reach was enormous. The National Audit Office recorded that the attack affected more than 200,000 computers in at least 100 countries. The health service in England was never the target. It was simply one of the largest institutions in the path of something that was aiming at no one in particular. That is why hospitals lit up across the country within a single hour. The malware was not being sent to them, it was finding them, the repair that already existed. Here is the detail that turns this from a disaster into a lesson. The hole that WannaCry climbed through was not a secret on the 12th of May. It had already been fixed. On the 14th of March, 2017, 2 months before the attack, Microsoft had released a security update known as MS17-010. It closed exactly the weakness that WannaCry would later exploit. Any computer that installed that update was protected. The repair was free, and it was available to anyone running a supported version of Windows. To understand why the timing matters, it helps to know where the weapon came from. The exploit that WannaCry used, Eternal Blue, was not invented by ordinary criminals. It had, according to Microsoft, been stolen from a national intelligence agency and leaked. In mid-April, a month after Microsoft's patch, a group calling itself the Shadow Brokers published the exploit publicly, putting a working attack tool into anyone's hands. Microsoft's own president, Brad Smith, later compared the theft of such a tool to the military having some of its cruise missiles stolen. So the sequence is precise and it is unforgiving. The flaw was found, the patch was released, and only then was the weapon dumped into the open. There was a window in which to apply the fix. For much of the health service, the window closed unused. There is a common belief that the health service was brought down because it was clinging to an ancient, unsupported operating system called Windows XP. The official record corrects this. The National Audit Office and the later government review both found that the majority of infected National Health Service devices were running Windows 7, a supported system that simply had not had the March update installed. Unsupported Windows XP machines were in the minority. That distinction matters because it changes the lesson. The problem was not mainly that the health service was running antique software. The problem was that a repair which existed for software that was supported had not been applied in time. Old software was a real weakness. The department said about 5% of the health service's computers and equipment were still running Windows XP on the day. But it was not the main door WannaCry walked through, and there was a second line of defense that also went unused. Investigators noted that whether or not a computer had installed the patch, properly managing the firewalls facing the internet would have guarded these organizations against infection. A firewall is simply the barrier that decides which outside connections a network will accept. WannaCry reached in from the internet through a type of connection that a well-managed hospital firewall had no reason to allow. Two locks were available: install the patch or close the door at the firewall. On too many computers, neither was turned. The warnings on the record. If the repair existed, why was it not applied? Part of the answer is that the warnings existed too, and we can lay them out in order. Mac, in 2014, the Department of Health and the Cabinet Office had written to hospital trusts. They said it was essential that trusts have, in their words, robust plans to move away from old software such as Windows XP. Temporary security support for old equipment would end in April 2015. After that, they were on their own. In July 2016, 2 official reviews of data security were published. They warned the department directly that cyber attacks could compromise patient information and could jeopardize access to critical patient record systems. The department did not publish its formal written response to those reviews until July 2017, 2 months after WannaCry had already struck. Then came the specific alerts. These were issued through a system called CareCert, the health service's channel for pushing out security warnings. When Microsoft released the March patch, NHS Digital, the health service's digital arm, sent an alert asking trusts to apply it. On the 24th of April, the telecommunications company BT passed on intelligence about a specific threat. The next day, NHS Digital issued a further bulletin, in effect an all-hands broadcast, urging the patch again. The later government review recorded a stark finding. Of the 80 organizations that WannaCry went on to affect, the number that had applied the patch advised in that April bulletin was none, and there had been a rehearsal of a kind 7 months earlier. In October 2016, a ransomware attack on the Northern Lincolnshire and Gould Trust had led to the cancellation of around 2,800 appointments and lasted 4 days. That same trust was among those hit again by WannaCry. It was not the only one with a history. Barts Health, one of the largest trusts in the country, had suffered a separate cyber attack that January, 4 months before WannaCry infected it too. The warning had not been theoretical. It had already happened more than once to the very organizations that would be hit again, a system that could not see itself. We now reach what the record suggests is the deepest cause. It is not technical. It is about who could see what. The Department of Health held overall national responsibility for cybersecurity in the health sector, but it devolved the actual work, the patching, the firewalls, the daily security, to local organizations, the hospital trusts, the general practitioners, the local commissioning groups. That is a reasonable way to run a vast, distributed health service. It becomes a problem when no one at the center can tell whether the local work is being done. And that was the situation. The National Audit Office found that before the 12th of May, the department had no formal mechanism for assessing whether local organizations had complied with its advice. NHS Digital could offer guidance, and it could inspect a hospital if invited. But it could not compel any local body to fix a problem, even when it had concerns about that organization's vulnerability. There was a hint of how bad things were. NHS Digital had run voluntary on-site security inspections, a program called Care Cert Assure, at 88 of the 236 trusts. The number that passed was 0, none of them, and the review of the attack later found a pattern behind that number. The organizations that took the advice seriously tended already to have mature security, while the more vulnerable ones were not acting. Trusts had generally not treated cybersecurity as a risk to patient care at all, and they tended to overestimate how ready they were. The center could not see the front line. It had issued warnings into the dark, and it had no way of knowing whether any of them had landed. When the National Crime Agency later came to investigate, it had to gather evidence site by site, the affected devices, the network traffic, precisely because that information had never been held centrally. The response plan had the same blind spot. A plan did exist, setting out who should do what in a cyber attack, but investigators found it had never been tested at a local level. So when the attack came, it was not immediately clear who should lead, and a cyber attack, the later review noted, did not fit the shape of the emergencies the health service had rehearsed. A traffic accident or a terror attack is intense but over within hours. A strike is slow but drawn out. A cyber attack could be both at once, long-running and highly intense, and it called for a kind of sustained coordination the existing plans had not been built for. Email was down because email was one of the things that had been infected or switched off as a precaution. And so, in the gap, frontline staff improvised, coordinating the report notes through personal mobile phones, including the encrypted messaging application WhatsApp. It was not an official channel, but the national bodies and trusts told investigators that, on the day, it worked well. The accidental off switch. The attack could have been far worse. What limited it was a piece of chance built into the malware's own code. Before WannaCry infected a machine, it did one strange thing first. It tried to contact a single web address, a long, meaningless jumble of letters that had never been registered by anyone. The logic buried in the code was simple. If that address answered, the malware would quietly stop. If it did not answer, the malware would run. On the 12th of May, a young British security researcher was examining a sample of the malware. He noticed it reaching for this unregistered address. Registering suspicious addresses to watch what connects to them is routine work in his field, so he registered it. The moment the address went live and began answering, infected machines around the world received the reply their code was waiting for, and they stopped spreading. The National Audit Office credits the recovery, in part, to a cybersecurity researcher who activated what became known as a kill switch on the evening of the 12th of May. The researcher was Marcus Hutchins, who described the events himself the next day. By his own account, it was partly accidental. He believes the address was never meant to be an off switch at all, but a clumsy trick to help the malware detect when it was being studied. Whatever the intent, the effect was real. The spread was halted. The fraud rushed. This is also why the weekend mattered so much. The attack landed on a Friday. Over the Saturday and Sunday, national and local staff worked through, applying patches and shoring up defenses, racing to prevent a fresh wave of infections when the health service came back to full strength on the Monday morning. By the Sunday evening, nearly half of general practices had applied the necessary patches. The kill switch had stopped the malware spreading itself. The human effort over that weekend stopped it finding new footholds. Both things had to happen, but we should be careful about calling this a rescue. It was a reprieve. Machines already locked stayed locked. The off switch only worked against this exact sample, and the researcher himself warned that nothing stopped whoever was behind it from removing the check and trying again. And between mid-May and mid-September, investigators identified a further 92 organizations, including 21 trusts, still reaching for that domain. The off switch bought time. It did not undo the damage, and it could not fix the underlying weakness. There is a coda worth noting for the record. 2 years later, Marcus Hutchins was prosecuted in the United States for creating unrelated banking malware some years before. In July 2019, he was sentenced to time served. The record is rarely tidy. What it cost and what changed. Let us be precise about the human cost, because precision is its own form of respect. National Health Service organizations reported no cases of harm to patients, and no patient data was compromised or stolen. That is the finding on the record, and we state it plainly. What was lost was access and time. National Health Service England confirmed 6,912 cancelled appointments and estimated the true figure at around 19,500 once repeat appointments were counted. About 1,220 pieces of diagnostic equipment, roughly 1% of the national total, were affected. 5 hospitals had to divert emergency ambulances, and National Health Service England's own review identified at least 139 patients whose urgent cancer referral was cancelled in the affected week. No health organisation paid the ransom. In money, the Department of Health and Social Care later estimated the cost at £92 million, 19 million in lost output, and 73 million in information technology costs, almost all of it spent restoring data and systems in the aftermath. The department stressed this was an approximate estimate because much of the data was never collected. As for who was responsible, in December 2017, the United Kingdom's National Cybersecurity Centre assessed that it was, in its words, highly likely that North Korean actors known as the Lazarus Group were behind the attack. The United States government said the same. In 2018, American prosecutors charged a North Korean programmer, Park Jin-hyuk, with conspiracy in connection with WannaCry and other attacks. He has not been arrested or tried, and North Korea has denied any involvement. We report the assessment and the charge. We do not pronounce the verdict. And what changed? In the immediate aftermath, the health service wrote to every trust, every commissioning group, and every support unit, asking their boards to confirm that all 39 of the security alerts issued between March and May had finally been implemented, and that local firewalls had been secured. The government then commissioned an independent review, led by the Health Service's Chief Information Officer, which produced 22 recommendations. Among them were 2 that speak directly to the failures we have traced. The appointment of a single senior figure, a Chief Information Security Officer for the whole system, to own the problem, and a commitment to run a national cyber rehearsal every year, so that the plan would never again be untested when it was needed. Money followed too, including a licensing agreement with Microsoft to move the health service to modern, supported Windows, and new central funding to strengthen local defenses. The lasting lesson is the quietest one. This was, by the investigators' own description, a relatively unsophisticated attack that basic security practice could have prevented. It succeeded not because the enemy was clever, but because a system had warnings it could not enforce, a repair it could not confirm, and a front line it could not see. The most important defenses were never exotic. They were a patch, a firewall, and a way of knowing they had been applied. This has been Findings of Fact. Thanks for watching. Every source is linked in the description if you want to dig deeper. If we got anything wrong, let us know in the comments, we'll pin the correction. And subscribe so the next investigation finds you. Or keep watching, the next one's on screen now.